No,
if we're live.
it's happening. We are live. Here we got Melissa with her bangs. We have Lisa wearing a shirt that's just all of expressing her deep love for socialism and the unions and big labor. Here we are.
Big labor, not socialism. Come on now.
Oh my
Weekends
God.
brought to you by unions. Yes, this is a union printed shirt. I did not buy this from like
Who
some
bought that for you?
reseller shady site.
Who got
Come on
it?
now.
Did you
Come on
did
now.
you get it from Instagram? Did Instagram flash it at you?
No, I sought it out and found the union made version. That's me. No
Oh
buying
my
through
God.
Instagram or TikTok for that matter. Ew. Gross.
I don't really use TikTok.
Hello.
I don't get it. I don't get it. Okay.
No.
Here we are.
No.
No. What?
Here
No
we are.
what? Oh, okay, great. Anyway, oh my God, you guys, I just got back. I'm really tired. Melissa, what's going on?
Well, we're live. I can see us, so that's good.
That's freaking great. Thank goodness.
Yeah.
All right. Here we are. Okay. All right, Melissa, I'm gonna send you away because here we are. Here's Lisa. Lisa, what happened this week? Oh my gosh, here. Do you want to see the deck I made for you? I made you a deck. You guys.
God.
So Lisa and I and Melissa, we have a Slack channel where we post. Well, actually, that's a lie. Where Lisa posts all of the things that she wants me to read throughout the week, and sometimes I read them, but a lot of times I just take screenshots. But we just got an announcement today from the big time royals that Princess Catherine has cancer, which is like sad because you know people were all like trashing that girl on the internet, saying her husband was having an affair, blah blah blah. So yeah, so pretty sad, but also data breach.
This is also the healthcare angle, right? Of course, it's even more tragic now knowing that like the outcome is that, oh, she was dealing with really serious medical problems and cancer. And someone tried to break into, or probably did break into her medical records within the fancy clinic that the royals go to, which is not part of the NHS, by the way. Speaking of socialism, Kat, this is a relevant detail for you. They do not go to an NHS clinic. They go to the London clinic, which is a fancy private clinic. So there you go. Their fancy private clinic broke into their medical records. Not great.
Well, you know, it's okay to have a little bit of elitism mixed in with the socialism, isn't it?
Well, I think the royals are the height of elitism. They're at the top. They're right up there by definition.
Fantastic. Oh my gosh. Okay. Well, yeah. So that sucks. You know, it sounds like maybe this. I don't know what's going to happen to this person who broke into our records. Maybe they'll go to jail. I don't know, British jail. Oh, but then this was an exciting thing that you also sent me. So this is a 2-part series here. So we have this guy's new company, which is like Hippocratic AI. But like, so this guy had some shitty company that went out of business, basically. But then Andreessen still gave him all the money because why not? I don't know, Lisa. I feel like this is like a normal story that happens all the time. Like these bros hang out and get like bajillions of dollars for like fake stuff. But this is the company they funded, this Hippocratic AI. They teamed with NVIDIA and they're going to replace nurses with AI for $9 an hour. Seems like a great deal. I don't know.
No, it is not a great deal because once again, this is not a nurse that is being replaced. This is literally a chatbot with a face that they are trying to sell as a nurse for a cheap price of $9 an hour versus an actual human being. And I just I just am so mad at saying that like you're replacing a nurse with AI when it's literally you're putting a face on a chatbot that may or may not be trained on something and you have no idea what the validity of those data sets are, where they came from. But in this case, we do know because the company that this guy previously had that like fell apart, he basically, as far as we can tell, and this is like allegedly, everyone put your allegedly hat on here. Allegedly used the data improperly from the previous company to train his AI models for this like nurse's fake chatbot nurse, whatever. So this is just a real bummer. This is just a bummer all around. Like you said, it's like tales old as time, like guy who fails at a startup gets funding again. But like in this case, it's pretty problematic.
Who's the guy, the WeWork guy, who, like basically imploded and then he raised, I mean, I'll tell you what, if reincarnation is real, I'm looking forward to being reincarnated as a
Yeah.
man. Like,
Yeah,
I think
yeah,
it's going to be
yeah.
awesome. I'm ready.
great.
Maybe I
Seems
too
great.
will raise lots of money. Yeah, I don't know. We'll see what happens. But anyway, this
No
seems like a pretty dumb
consequences, man.
idea, to
No
be frank. Yeah.
consequences no consequences. Just everything is great. Just keep going. Lowest
Yeah.
common
Maybe
denominator.
you know
Totally.
what, Lisa? Maybe I'll start Theranos again as a man. And then
Yes.
when I harm all these people, they'll just like let me go. Like, I don't know. We'll see what happens. Who knows? Anyway. Okay. This is a really, yeah. So speaking of being a woman, it turns out that instead of giving people, it sounds like just DNCs when their pregnancies are no longer viable, we're now just giving them C-sections.
Yeah. And if you don't know, because you don't have experience with this, a C-section is a really, 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 really serious surgery where you cut through everything on the outside to get to the inside. It's a real serious thing. It's not a minor, like, chill, like in, 6 a.m. out at noon kind of sitch. It's like a serious surgery. And a
Yeah.
DNC in most cases is really quite a safe procedure that is not nearly as invasive as cutting a hole in whatever is right here.
Multiple layers of tissue, muscle, organs.
Look it up. There's probably videos of it on the internet, and you can see what actually is involved in it. It's a big deal. Not great.
Yeah, it sounds like Louisiana's going to hell in a handbasket, but I believe this is in other states too. This is just I think Louisiana was the subject of the report, but
someone raised the alarm. Yep. Not great.
Once again, Lisa, when I'm reincarnated as a man and I become a state senator, oh man, I'm gonna do so much crazy shit.
That's your top thing you're aspiring to is being a state senator when you're reincarnated as
a male state senator.
I'm gonna be president. I will be president then, and we'll talk later once I'm reincarnated. Okay. We'll see.
All right. We'll figure it out. But yeah, I mean, the bummer here too is, as Melissa notes in our comments, like, if you get a C-section, y'all, like, it's actually really like difficult and complex to give birth vaginally. Like,
it's called VBAC.
Yeah.
Vaginal birth after C-section.
It's a real thing. And like, there's all kinds of shit that can go wrong because you're cutting through all those layers of like, tissue and organs and stuff. So anyway, this is a load of bullshit. Once again, I don't really have any options for everybody here other than like, this is bullshit. And, maybe we should just all move to blue states. Not sure. Go unions, Lisa. Well, you're like converting me. You're converting me on the fly here.
Unions.
Oh my God, I can't even handle it. Okay, okay. The other thing here. So this is I'm getting like my energy back. I've had like kind of a long day. Okay, in other news, as everybody knows, we hate Medicare Advantage. We hate it so much. But like, there's an interesting thing here. It costs the government $83 billion more to provide coverage through private Medicare Advantage plans than traditional Medicare. Weird.
Well, I mean, it's complicated, as Larry says here. It's complicated as well. So is the story, right? Because basically, so number one, Medicare Advantage plans siphon off healthier Medicare beneficiaries in the beginning. And then as allegedly, they perform a lot of upcoding to make those beneficiaries seem sicker than they are so that Medicare has to pay them more money to serve those people. At the same time, Medicare Advantage plans also offer more services than traditional Medicare, like in some cases dental or whatever else, and all this copay. So, it's a complicated story. It's not that complicated. Like, ultimately, we know that there are problems with the current Medicare Advantage plans. I just want to state for the record that Kat is the one who hates Medicare Advantage. I always just say it's complicated. So, just
I hate
anyone who's asking.
Disingenuous marketing tactics employed by Medicare Advantage plans. Those are the things I hate, just to be clear. But we do seem to be getting a lot of news about Medicare Advantage being the worst.
I hate, I think I can say this pretty plainly. I really strongly dislike the use of algorithms to deny care, to do illegal prior authorization. Generally, I dislike the use of these things to stop people from getting care that they are entitled to. That is my no BS policy position. Stop it. Stop it.
You fucking tell him. Hey, speaking of upcoding, whatever happened to Alidade? Did they successfully PR cover up their case by pretending to give money to practices? What happened?
These things take a long time to shake out. To be fair to everyone involved, change is like still not really resolved, right? Like, is it live again? Did everyone get paid? Like, I doubt it, right? Like, not the alive part, but like, did people get paid for all their past care? I'm pretty sure that hasn't happened yet. The check is in the mail, allegedly, right? So, like, I just think that's kind of check is in the mail. I am sure that there are practices that are struggling. I certainly hope Alidade has cut some of those checks to those practices. And the other issue, the whistleblower complaint, those things it's going to be years before we know anything else in that story, right? It's just like, that'll be talk to us in like 2027 if we're all still alive.
An ongoing topic. We might not be alive because someone may give us an abortion if we accidentally get pregnant or a C-section, and then we might die of sepsis. So like, we might not be here. I don't know. Who knows what's going to happen?
You never know.
All right. This I just thought was funny because you sent it to me. So apparently there's this law here. So you can only steal data if you're a US based corporation, allegedly. I don't know.
Allegedly.
Okay, but speaking of stealing data or like being not cool, so I wrote this post. I put myself in here, Lisa. So I wrote this post yesterday while I was like mad. I was mad because there's a lot of really shitty companies out there that don't understand data use rights and allowable purposes for using the national networks. And like, there's been like all this scuttle, like there's screenshots being passed around of like these shitty companies and their shitty salespeople actually saying, oh yeah, it's not a treatment purpose, but like we can get it anyway, right? There's like all this shit out there and like no one's doing anything about it. And so like, I've had a lot of these companies, and I know, Lisa, people ask you too, and people ask everybody like, are we missing something? Like, is it like, can you suddenly like pull payment shit from the national networks? No, you cannot. No, you cannot. That's shady as fuck. It's shady. Don't do it. Don't believe these people. Yeah. Like if they're telling you it's fine, but you're like, like you should probably trust your gut here. So this became a mild internet sensation over the past day. People were concerned that I was getting a divorce, that I was leaving in Senna, that someone hurt my feelings. Like there were all kinds of things. No, you guys, I'm just mad at data aggregators that are pulling from the national networks for purposes that are not allowed. Like that's it. Yeah. That's it. I'm just mad here. So anyway, Lisa, do you have any feelings about that?
I mean, here's what I will say. Once again, governance matters. Unsurprisingly, I would take that, stance. And I think it's really important if you're going to set up something like, a governance council, let's say, of networks, you might want to make that be really, really, really accountable, where you have to follow specific rules to like stay in that collaboration, let's call it. I mean, you need to have that oversight that is not just one person responsible for ignoring all the complaints that have been sent and all of the information out there. You have to think about, why don't people report this in a more public way? Because they're like a small fish and the other guy is a bigger fish, and it's going to affect their business model. It's really hard to do this as a small company and say like, hey, like this feels real shady to me. It's like, okay, do you want to stay in business? These are real issues that governance models have to take into account. How do we do compliance, and how do we make sure that people are actually following the requirements, not doing shady shit? You have to have those structures in place before the shady shit happens, and then follow up.
Exactly. The other bummer is like, like you're saying, like a lot of these companies that are trying to connect, they get these, they get these emails, they get these calls.
What are you going to do?
Someone's saying something shitty, but they're also under NDA, and NDAs really are kind of worth the paper. Like they're not even worth the paper they're written on in most cases. Right. But like, it still deters a lot of people from like saying like, hey, this doesn't seem right. And that's like bullshit.
Right to me.
Like you guys, like I actually care about protecting health information. Like I actually care about it. Cause like, here's the thing, either like, let's just make let's just sell this shit on the internet, like free and clear. Or like, let's actually like follow the rules. Like, I don't know. Because right now I feel like it's like, bleh. So anyway, that's what I'm mad about today. And no, I'm not in personal distress. I did have someone send me a free subscription to a meditation app. There's like people really care, and like I feel great about that. But no, in fact, I'm just mad about.
Yeah, she's good. She's good.
Like it's fine. It's fine. Lisa would know. It's okay. Anyway, okay. Well, I think that's it for the news show. So we've got like some real guests. Lisa, would you like to introduce our guests? Yeah.
Get some real
Okay. So
guests.
first up, we're doing Shamekka, right? Here she
Shamekka, Marty is up first.
is.
Hi.
Oh my gosh. So you guys, listen, we met Shamekka on the internet, like we meet many of our guests, and she was like a super fan before we met her, and then like she came to our Vibe thing, right? Is that how it happened?
Amazing.
And we
I
met
don't
her in
know what
person. And we
conference
took
it
a
was.
selfie.
5 hymns, anything else? I have no
Yeah,
idea. I don't know what day it
doesn't
is.
matter. Oh my gosh. And she actually sent us some real topics that she would like to talk about. So like I'm
Yeah.
like ready. So Shamekka, introduce yourself to our loyal fans. There might be, I don't, who knows how many there are. It could be 100, it could be 5. I'm not sure.
Well, first, I just want to start with you have your Theranos look.
Oh yeah, listen, I'm ready. I'm ready. Like when I'm reincarnated, I will be ready.
One hair. Yes.
No, I'm like
do
next
find you
gen
guys online,
Theranos.
and I started watching and everything, and I made sure that I stalked you at Vive because they wanted me to make sure that I get the prime people and sit in on perfect shows. And I was like, oh my God, they're right there. Yay. And I'm geeking out. Let me take a picture. But yes, so I made sure that, and then I hit up Melissa and I was like, please put me on your show. We have to talk.
That's the right thing.
Interoperability. Yes.
Yeah, Melissa's the real boss.
I am that one. I'm the connector.
Yeah. Okay. So you got a lot of stuff going on. So like we looked you up on the internet. Like you're a patient advocate. You've got this whole. Well, it looks like you have been diagnosed with many things that seem very hard. And then you're also like an interoperability person. Like just like I don't know. Just tell us some stuff. Like what?
I struggle. I don't even know who I am anymore. I do have lupus and several other autoimmune diseases and counting, but it started out with lupus, and that's why it started Pretty Sick Lupus Chick, and empowering people and making sure that patients and caregivers have a voice. I didn't have a voice. My mom didn't have a voice when she was younger, and as you can see, I definitely have one now. Making sure people know that this little girl, this little 5'2" girl, is not a force to be reckoned with. And I make sure to empower people who do follow me, because navigating through the healthcare system, it's a constant battle for me, especially with interoperability. I mean, I encountered a doctor the other day, actually yesterday, I had to rip him a new one because he happened to be a doctor that didn't have electronic medical records. And that was something that wasn't serving me. And his response was, I don't want to get into the bureaucracy of everything. And I'm like, but you're not helping me when my doctor wants to look at what you did. I have nothing to give him. I made him feel so bad that there were 8-page notes and letters to my other doctors. And I said, no, that's not how we work. This is not. Is there a law against this now? Can we make one? You need to have something where I can refer back to and give to other specialists, because it's not helping me.
Wow. Okay. Oh, Lisa, go ahead.
I guess I know that it happens still sometimes, but it's very rare to have a doctor who is managed to avoid slash done all of the like hardship exceptions and whatever they have to do to get themselves to not be using electronic medical records if they are in any kind of federal or even state program in many cases. That's wild that they would not. That's just like, okay, great.
Yeah.
So
that was a red
Shamekka,
flag.
So tell us, like, so you have, you've been diagnosed with all these conditions. You're clearly like navigating your own situation here. Like what's your personal experience with interoperability? Like, it sounds like potentially failing you is the story.
Yes. So my personal experience is I was taking care of my mother who had lupus at 10, and also my grandmother who had severe rheumatoid arthritis. She was bedridden. And so I had to grow up really quick, and I was taking my mom to doctor's appointments underage because I didn't have my license. She didn't really trust anyone. She didn't want to open up to anyone. With the Medicare system, my grandmother, wasn't working. And so it went from, oh, okay, she has coverage for this many days. Now we're going to take it from 7 days to 5 days, 5 days to 3 days, then to 2 days. And I'm like, you think she doesn't need anything the rest of the week? She doesn't need someone to help her get up and help feed her and do all this stuff. So then the onus became on me or my mom when she had enough strength. So learning from that back in the 90s, and then coming here, we're far enough where we have electronic medical records, and I'm the one grilling doctors and paying quarterback when I shouldn't be. it made me mad. Either you're a part of the problem or you're a part of the solution. I want to be a part of the solution. So that's why I jumped on it.
Yeah.
That's
So,
awesome.
so you actually you are working in the industry as an interoperability expert, cybersecurity. So so is that how this happened? You were like, whoa, this is like jacked up and I'm going to fix it.
Yes. And I
Okay.
wanted to make sure anybody that would listen to me, what do I need to do? Sit down, educate me. Before electronic medical records, when I moved to California, I'm originally from New Jersey. They didn't really have it. So I had this big old binder, big ass binder with a whole bunch of stuff in it. And I had to section it off and be, organized. The fact that I'm a project manager helped a lot because I'm all task oriented and making sure I'm following up. Because you ultimately, when you have an illness, you have to project manage your life. You have project manage
Yeah.
your doctors. You have to put them in contact and, okay, well, this is my specialist. Can you talk to them? And then going online, learning the medical jargon so people could take me seriously. And that's what I was like, okay, if I'm doing this, other people can do it. I need to help other people be able to do this too.
Yeah, and I think, we happen to know at least a couple of other amazing patient advocates who are both in the industry, have found their way into the industry, and then are also obviously, their own patients dealing with complex chronic conditions. And that certainly, I think it's a really important combination to make sure that people who are doing the work have a grounding in issues that are really important to patients. And I think, I personally care a lot about making sure that your voice gets out to the world along with your peers and everybody else who's dealing with serious chronic conditions or has been a caregiver and really understands that approach. The problem, of course, is that, as you probably know, all of these regulations and laws are built around this structure where they say that what's important to the patient is the most important thing. But then in reality, when we see that actually get implemented, the voice of patients is at best secondary, like at best, at best, at best. And I think,
Yeah.
I would love to hear your opinion as much as you feel comfortable sharing about the current state of the law and regulations and the reality on the ground for patients like yourself and people and how you would like how do you see the current landscape?
Well, I went to the ONC, and I think they were surprised because at the end of each panel, I get up and be like, "Hi, so actual patient. Who are the patients that you interviewed for this? Because none of this stuff actually works for people who are chronically ill. This is for someone that had a cold and then they move on with their lives. This doesn't help a 65-year-old grandmother who can't speak English, who has to utilize their granddaughter or grandson." And they were just sitting there like, "Who let this little girl in?" And, literally, like the one lady, she had a nice story. I had this and I had to deal with this with my son, and he had this condition, but he's better now, and blah, blah, blah. And I was like, oh, that's really heartfelt in a nice way. I said, that's great. But nobody else thought about this. And each one that I went to 3 different panels and made sure I let them know I was here. And they were just like, okay, we want to speak to you. And I said, yes, you do, because I don't know why you're trying to pretend that you talk to patients, because obviously you didn't. You want to act like you did, but you didn't.
This is really interesting because it's almost like when we made the case that there should be a chief patient officer at HHS, people said, well, there's just like, who could possibly speak for all patients? We're like, well, nobody. But also, there are lots of amazing people who are extremely qualified who could be an appropriate chief patient officer working with HHS. And just one more example we're putting out there into the world. Thank you, Shamekka. You're on the list.
Yeah.
Well, I have to thank my wonderful mentor, Grace, Dr. Grace. You all know, yes.
Grace
I hope she's watching 'cause I'm putting
Cordovano.
her out there.
Yeah, well, she is a hero. I think all patient advocates that spend the actual time, right? Like that's what's crazy is like you went to those panels and it sounds like you did it like you went on your own dime, right? And like spoke up.
Yes.
And
which is
a
ridiculous.
lot of patients, oh right, a lot of patients like they can't do that, right? And they're so busy trying to figure shit out that like no one's gonna go and like go to an ONC panel at a conference and give them that feedback. Like it's just kind of like a load of bullshit. So yeah, I don't know. Other than Lisa and I have our small little idea to get someone installed. in HHS. But yeah, like what are other ideas that you have? Because like, you know, we're into incrementalism also.
Yeah, definitely having someone that, I read all of these job descriptions for someone like a patient officer, and none of it says life experience. You went to school for it. I'm so
Mm,
glad. And a lot of people that did, they don't understand because it's really not their life. It's just like a doctor. I don't expect for the doctors to completely understand me. I am not textbook. But then you have to take that into consideration and put someone that has the experience, that can speak intelligently, that you can invest the time to help make sure that they learn.
amazing.
Because every night, I don't know if you saw my LinkedIn, I'm pumping out a new certification, epidemiology, public health equity, health, and I'm going through this and I'm taking the time because it means something to me. And I'm like, they're going to take me seriously. I'm going to make sure I know what TEFCA means. I'm going to know what all this other stuff means. If I have a regular conversation with someone, they have no idea what I'm talking about unless they are in the game. And like you said, a lot of patients can't afford. I went on my own dime because I'm like, I'm going to be known. I know that we need to get someone out there, and it's unfortunate that they don't at least have patients allowed to go there and they can foot the bill because it actually means something to them. Don't say that, patients are number one and you're not even helping them out. You know that they don't have the money. I'm over here working 5 jobs to make sure that I can do this. I do consulting, I do motivational speaking, I do many other things, but I'm the weird unicorn that can get this done, and I don't care. I'm going to do it. But that's where you say if somebody's going to have that position, I think that they should have real world experience on top of their education.
That's so well said, and I can only just say that I 100,000% agree with you. And I would love for us to continue to push that message forward. What we can do is we can tell the organizers of these conferences that they need to have honorariums and sponsorships for patients to attend and be part of this work. They need to have, I think, obviously what happened at Vive and Health and what's been happening for a while with the Ask a Patient. What's it called? Like the pavilion or whatever it is. Like
Yeah,
that's great.
yeah.
That needs to also be backed up with like support.
Yeah, that's why they were surprised. They were like, "Who let this patient in? How did she afford to come here?" And I'm like, "Well,
God.
actually, Mark Nees had recommended me to come. He said you should go up there." And I said, "All right, I'm there." So I'm glad that he's moving up in the ranks. I believe in him too. But yeah, we need to talk about interoperability. We need to talk about AI in the patient voice. There's so many things like the prior authorization, which you touched upon earlier. These algorithms are set to wean people down and just make them give up. If my grandmother were alive and she had to do the things that I have to do to schedule an MRI, she would have gave up and it would never happen. They don't have the
Right.
energy. People don't need to go through this and think, why was I denied? I pay for this service. Why can't I have this service? But we don't put that same energy into ourselves. If we order something at a restaurant and it doesn't come, oh no, I need the manager. I need the manager right now. And we don't do that for themselves. Okay. So we need to have people in place to stop these things.
That's amazing. So actually, just shout out. There's an amazing episode of the podcast "An Arm and a Leg" that came out yesterday. That went specifically into the Navi Health experience, where Navi Health were using, and are, I don't know if they still are, we're using an algorithm to deny people nursing home care, among other things. And it's a really great episode, great podcast, and really recommend it. But the story, I mean, I think people should just listen to it and see if you feel okay about the way that algorithms and other tools like that are being used to deny care and to really put tons and tons of roadblocks and barriers, like you just said, Shamekka, like that is and the way that they do it is in an escalating way where the denials come very, very quickly. And then not only do you have to organize your response to that, you have to do it faster and faster. And it's really incredible what kind of things we have done, how much we've invested in to deny people care versus trying to get them care. It's really amazing to me. Really shocking.
Yeah.
I know firsthand on just the VA. I haven't even gotten into that, but I have a lot of friends that are retired VA that need help, and they may be on disability, and all of a sudden they get a letter saying you've gotten better. Well, how did I
You're
get
like,
better? I
nope.
mean, did I get a bionic body out of nowhere? And why is this happening? And I don't understand why they just automatically send these things to start testing people and be like, oh, let's see if we can cut this person. They won't fight too much. Why would you
Right.
do that?
Yeah,
Right.
that's freaking wild.
And there's another one. I might be mixing up the podcast now because I listen to a lot of them, but there was a story about someone with spina bifida and their wheelchair broke, which is obviously incredibly critically important for doing anything in your life. And they're like, why are you denying this? Like, what do you think is going to happen? What happened? How did I recover and suddenly not have spina bifida? Like, in what planet would even an algorithm think that is possible? Like, how could I not have spina bifida from one day to the next? Like, stop. It's just, it defies reason.
No, those are all the things. Even with my medication, when I was taking chemotherapy, before I could get authorized for it, I had to take generic medication. And I would ask them, why can't I just get the regular kind? And they're like, no, your insurance says you have to take the generic first, and then they'll authorize the regular brand. And I'm like, okay, so you want to go the cheap route, and it doesn't have the full effects, and then see where that goes. And then someone taught me a trick of what to say to avoid that. Just tell them you're automatically allergic to it. And I'm like, why do I have to go through that?
Yeah, it's a load of
This is what
freaking
the insurance
bullshit.
companies do, the payers do, whatever.
Yeah,
I mean,
that's
it's
a load of
tricky because
bullshit.
it's tricky because there are certainly people, in particular individuals, who do not want to go into this to deny care, right? The example of Navi Health, there were people who quit their jobs because they were like, this is unethical. Like, I can't be part of this. And that happens probably everywhere when people are in the business, when there's a corporate policy to deny care. And so, it's tough because there are a lot of people who care and do want to do good work. And then there's this like overarching structure that is like forcing them to be part of unethical decision making.
Yeah.
Exactly.
Hey, so Shamekka, you brought up that you've educated yourself on TEFCA, and what do you think of the promise, as in not reality, of the individual access provisions in TEFCA? Like that it didn't like really happen? What do you think about that?
I don't feel like it's really happened. I haven't seen change. I see that a lot of people are putting their hand into it to make things better, like with applications and such. But I believe that they can do more. They should mandate, and I know that there are big companies such as Epic and Cerner, and it really just boils down to how much is it going to cost. But we need to have some sort of regulation that mandates every provider has electronic medical records, some type of system that can talk to them. I know there's like an old bill that prevents it and stuff like that. That's where I'm like, if they got rid of that bill, if that's something that is blocking it from other systems talking, then that's where we need to direct our energy to. Because there's no reason why, if I go to a Mayo Clinic, that it doesn't transfer over to a Stanford.
Yeah, I'm not so sure that law actually exists anymore, or I think that I don't know if that's a real thing. I think a lot of people just come up with reasons why they can't share. But I also want to say you called out this guy Mark Nee, so I just met that guy. He seems pretty legit.
Yeah, he's great. He just got a promotion.
Yeah, he just
Congratulations,
keeps getting
Mark.
promoted.
Yay!
It's great. Promotions are awesome. God bless America.
He's also an attorney, and for those who work in government or have worked in government, government attorneys. He's not working for the government as an attorney. He's an attorney who works for the government in policy. So he's got he's a good person to understand sort of the ins and outs of it, and just really seems to have a great approach and a great thought here. So I'm excited that he's moving forward at ONC. Go Mark!
Yeah. People that want to do stuff like I'm into.
Yeah.
So yeah, hopefully we'll get to hear from that guy more. But yeah, excited that there's someone moving up that's doing the good stuff.
I think he's also Tom Novak's official boss, which we found out recently, which is hilarious to me.
So
Tom
you're welcome, Tom.
And it's Mark.
Yeah, you're welcome. Yeah, friend of the show, secret friend of the show, Tom Novak.
Secret friend of the show,
that's great.
Tom Novak's actual boss.
Yeah, that's wonderful. That's wonderful. So, Shamekka, what do you think of some of these companies that are like the Datavant news we covered last week, right? There are a bunch of companies that are like kind of at their own cost, making available patient records for free to the patient. Like they're kind of like doing the good thing, even though those aren't, as far as I know, complete data sets. But like, what do you think about all that? Do you think it's like just softening the edges, or is it actually like pushing us in the right direction? What are your thoughts on that?
I think it's going in the right direction. I don't think we're there yet. I think because there's so many different systems that have to be encompassed. I've sampled a few of them. There's one from eHealthcare Exchange. Clear is dabbling into one, and I see where their mindset is at. And I'm like, yes, but we need more options. And when I say more options, there aren't a lot of hospital systems that are listed. So I think it's more of adaptation of getting them a part of it. But they're going in the right direction. We're still not far enough that I would like, especially in this age of technology. I think everybody's like, yeah, we were going here, here, here. Here comes AI. Let's go this way. Everything is AI, AI, AI. And I'm like, wait, let's go back. We still have to go here.
Yeah, let's go analog. Well, what do you think about AI? Because I know I've been seeing a lot of stuff from a bunch of the patient advocates, including Dr. Grace Cordovano on the internet, about the patient voice not being necessarily included at all in any of the AI technologies built for healthcare. So, what are your thoughts on that?
I think that it's helped to make doctors more efficient to help save time, but it's not listening into the patient voice. There may be auto generated things that you're like, that's not what I said. That's like, it's going online and you're talking to someone for your bank. And automatically you get frustrated. You're like, representative, representative, representative. And you really can't do that when you're sending a message, but it's an auto generated message because you know you're not talking to a live doctor at that time. So it's not encompassing like this will not always have a response for everything. It'll have a general one if I say, hey, can you refill a prescription or something like that? But if I'm describing, hey, after this happened, I don't know if I need to go to the emergency room. Honestly, people who are sick dread going to the emergency room. They just feel more comfortable speaking with the doctor and not having that patient voice in there. Everybody is getting burned out. So I see where this could help, but we still have to make sure that our voices are heard, that you have to tailor it, that it just can't be just put in chat GPT. The patient is complaining of this, and then send off something that doesn't have real good bedside manner. It doesn't help that we're not the end users to help tailor this. And that's where I'm like, okay, let's start there. We need to be a part of this. Where are the test scripts? Now I'm going to get all cybersecurity. We need to do test scripts. Have you pen tested this properly?
Yeah, all of that.
Probably not. Yeah, yeah. Okay, so Shamekka, we gotta move on to our next super guest here. But like, what do you want to leave our audience with? Like, what should they do now?
Talk to legislation and let them know that we need to have better safeguards in place for our data. Even though I'm talking about interoperability and we have it, the things that happen with United Healthcare and all the things that are just happening now, remember, everybody's important. Everybody's important. It may not be important to you right now, but it will be important to you at some point in time. So just make sure that you keep your voice open. It's okay to have a voice.
Yeah. So I have not been reincarnated as a man yet and become a senator, but write to your Congress people. My
Yes.
favorite statement.
It's the
That's
revolution.
right.
It's the revolution, people.
Look them
Give
up
them a
on the
call.
internet. Give him a
Thank you,
call. Yeah, give him a
Shamekka.
call.
You're awesome.
Thank you, Shamekka. You are
Thank you guys for
awesome.
having
All
me.
right. Absolutely. Give us a shout. Okay, so next up we have Amy Gleason, who's like pretty much a celebrity as far as I can tell.
Pretty
Everyone's like pretty
famous.
pumped that she's here.
Pretty
Oh my
famous.
God. Yeah.
Hello.
Like, oh my God. I don't even know what you do anymore, Amy. You're like doing this rural health thing. You were like United States Digital Services. You were a co-founder. What are you doing?
So I'm the Chief Product Officer at Main Street Health now. And as you said, we work in rural health. We're reinventing rural health to bring access and quality, especially in handling social determinants of health for patients in rural communities. So we partner with existing primary care clinics that are 3,000 to 5,000 person towns, so really rural places, and put a health navigator in those clinics to really help drive a lot of the value-based care activities and improve access and quality to care.
That's amazing. But
So
that barely describes it, though, Amy. I mean, you have quite a storied background in healthcare innovation.
Yeah, so
A
I
little bit
started
more.
out as an in nursing in the ER a long, long time ago, and discovered that technology powered things that could make things better. And so I moved into technology pretty early in my career at a startup EMR that launched me into healthcare tech for many, many years through inpatient, outpatient EMRs, lab systems, hospital systems, pharmacy systems, you name it. I've kind of done that gamut. And then my daughter was diagnosed with a rare disease when she was 11, went from being a competitive cheerleader and gymnast to not being able to stand up off the floor or walk up the stairs. So it's kind of crazy to see your child go from such a energetic, muscular, fully functioning child to not knowing what's wrong. It took about a year and 3 months for us to get a diagnosis. She saw many, many doctors, broke 6 bones through that time. We just couldn't figure out what was happening. And eventually she was diagnosed kind of by accident at the dermatologist, where they did a biopsy to get something covered by insurance and realized they were going down the wrong tree and found out she had this really rare disease. There are about 2,000 kids with it in the US called juvenile dermatomyositis. And that day I kind of became lucky, and through my reading every single page of Google, I found a patient advocacy group called Cure JM and found a parent the very day she was diagnosed. It was a Friday night, and I put this message post out, and a mom responded to me within an hour and said, "Can I call you?" And she said, "My daughter's had this for 15 years, and get a piece of paper and a pen, and I'm going to tell you everything you need to know." And she gave me this doctor's email on a Friday night, and I'm like, I mean, I'm sure she's not going to really answer me, but I emailed this world famous doctor in this space, and she replied within an hour and said, "I will see you in July. This is what you need to do in the meantime," and just gave me all this information. And we really learned so much from all the other parents. They're the ones that can really tell you how to live with the disease. The providers can provide you treatment and help you get the medical care, but they don't really understand what it's like to be 11 years old and not have the same strength and be able to do gymnastics and cheerleading with your friends, and that you lose your friend group when that's your whole identity when you're at that age. That trying to get teachers to work with you on assignments and going to school all day long was too much for her. She didn't have enough energy, but she didn't want to miss her friends and have no socialization. So we did half days at school, and she did half online and half in school. Those are kind of the things you learn from other parents. Also, rare diseases providers don't really know that much about what it's like to live with the disease. So sometimes they would tell us, "Oh, that symptom's not part of this." And then we talk to other parents and they're like, "Oh yeah, my kid has that. Yeah, my kid has that." So I co-founded a company called CareSync that was really aiming to solve that, helping patients get their medical records and sharing it with all their providers and giving the family a whole way to rally around the patient. I found one of the hardest parts is I was the only one that really knew all the things about her, and she was seeing 12 different doctors across 6 health systems in 3 states, taking 21 pills a day, going to the hospital a couple times a month. And it's hard to pass that off even to my husband, who was very involved and wanted to help, but it's just so much information. He didn't feel comfortable taking her places in the beginning because he didn't want to mess up and miss something. And so we built a tool to help with all that. He could know the right questions to ask and even record the provider conversations, and I could hear that in case I was at work or traveling or whatever. So we built this system that had health assistants to help patients. And then after that, I did my public duty tour at the U.S. Digital Service, which is part of the White House, where it really is kind of like a startup in the government, where we tackled really challenging technology problems, but also where they intersect with policy. So I was there to mainly work on healthcare interoperability with CMS, and I built a product called Data at the Point of Care. And that is allowing providers to get claims data for their patients, their Medicare patients. So claims data can't tell you everything. It's not a clinical record, but it can tell you the doctors that the patient sees, the problems they have, their medications, maybe where they had a test. Did they actually show up to the cardiologist you referred them to? So that was a pretty exciting thing. CMS was the first bulk fire implementer because of that product, which was kind of cool.
It's real.
That's awesome.
It can be real.
If CMS can do it, anybody can do it. That was my whole thing. But then I was there when COVID hit, and I got detailed to Dr. Burks on the White House task force and built out the federal database and surveillance systems for the federal government. So find out where hospitals needed extra beds built, or whether they had supplies, or where we just shipped remdesivir. And then through that process, realized how hard it was to get public health data from the local and state health departments. And so we worked with the CDC to modernize their surveillance tools for test reporting and all of that, hospitalization reporting, et cetera. So that led me to meeting Brad Smith, who founded Main Street, and that's how I ended up here.
And Brad Smith was
Wow.
the CMMI director as well for a short year, a brief year, following up from Adam Bowler. And yeah, I mean, you've done a lot, Amy. You have really you were in these places at some really critical times for the development and the application of interoperability rules. Obviously, we all work together with our other friend of the show, Shannon West,
Yes.
and just really made a lot of things happen. It's so interesting that you say that about data at the point of care. You know, I was thinking, I mean, you may have heard or seen that CMS is rolling back availability and accessibility of some Medicare data, but at the same time, like kind of almost quietly, again, like shout out to the people at CMS who've been working on this for some time, Mina and Alex Muggy and her team, all of those people. You know, they're just like plugging away at making more and more data available through standards-based APIs, not talking about it a ton, making it happen. You know, it's really interesting to think that how far CMS has come since we all started working on this.
Yeah, it's pretty crazy. We actually use the data at the point of care API at Main Street, so that's
Amazing.
even crazier to like use your own thing, eat your own dog
Wow.
food. But it's interesting too, the use cases that we had. There are all these other things I didn't even think about, and it's amazing to get to use those and see the power of the data. So it's pretty cool.
It's
Yeah.
awesome. So you actually did stuff, which is really awesome. But why rural health? Like what attracted you to Main Street Health and that challenge?
Well, for one, my family is from rural areas. My mom grew up in Kosciuszko, Mississippi, which is a very tiny town in Mississippi. And my dad is from Opp, Alabama, which is also very tiny. And I lived in a lot of small towns. My dad was a hospital administrator, and so we transferred around a lot and went to small rural hospitals. So I have a passion for rural towns. I think it's challenging to get access to the right care there. You know, you might have an oncologist that comes there once a month, or you might have to drive 3 or 4 hours to go see a specialist. There might not be a primary care doctor that's within 40 miles of your house. So I think it's challenging for people to get access to the care. And I think with technology and the power we have of using data to also improve things, delivery options and virtual options, there's just so much you can do now that you couldn't before. And so I think it's a great opportunity to help people in that community get the same healthcare you could get in the city.
Yeah, so I just did a couple of rural health panels at Vive and South by Southwest. And one of the reasons I wanted to do them is because I feel like I'm often on these webinars or live sessions where someone is telling me the solution to all health ills is to get someone a lift to get them to their appointment or send them a food box. And it's like, oh, good God. Like, I don't know if you guys know this, but in like Western Nebraska, there's like no rideshare. So I don't know if that's it. But like, so it sounds like you guys, you said care navigators. That's what you're doing, is kind of like installing them in these towns. Like what else is it? Like what's the solution? What's the secret?
Well, I think the health navigator is a big part of what we do, but also the data and the technology is a big part. So we take in, you know, these rural providers a lot of times don't have the most sophisticated technology or staff that even knows how to get all the data from health plans that's offered, or from ADT feeds, or even SureScripts or different things like that. And so we take in data from all over the place, and we don't just feed that to the providers. We take it through a bunch of work, clean it up, and present only meaningful insights to them. But we more often present it to the navigator. So the navigator can do a lot to really intervene. So if they didn't pick up their medication, they can help them figure out how to get that, whether it's that they didn't make it into town to get it and they need to go pick it up and drive it to them, or whether they need to set them up on delivery, or maybe it's just education on why it's important to take it. The navigator can do all of that, without anybody else being involved if they have the right information and the right script and the right tools. Same, ADT feeds. I know you know a lot about those. We get ADT feeds from a whole bunch of different sources, and then we call the patient, hey, we see you were in the emergency room yesterday, get them back in for a visit, make sure that they got all their discharge meds and any DME or anything that they had, just simple things like that. And then even just making sure they come in for their visit, they're diabetic, that they're actually coming in regularly and getting tested, and they're getting their A1C checked and their eye exam. I mean, those things are all things that a navigator can do. And because our navigators are from the local community, it's their teacher or and so they're known in the community. They know the resources. They know, the church that drives people, even if it's 40 miles or whatever. And they're the only really non-scheduled resource in a clinic. They don't have appointments all day. They can spend 6 hours on one problem if they need to. So they can call the electric company and get their power turned back on, or whatever they need to do, they can take the time to do it.
That's really
so
awesome.
It's interesting what you were saying. So I also grew up in a rural community. People don't think of it as maybe immediately as super rural, but I grew up in rural Northern California. And for what you were saying, Kat, like food box, we lived, I want to say like 5 miles from the road, right? Like you literally, I don't know where you would drop off a food box, but you couldn't leave a food box at our like mailbox. Like there's and nobody, like just the practical things that people don't understand when they're trying to recommend solutions that work in non-rural settings. There's just so many things. We didn't even have electricity. So like, I don't know what we would have done. It doesn't, I realize that's a little bit odd, but it also happens, right? Like people don't have solid connections or whatever it is, right? We barely had a phone line. So, like just this desire to apply just solutions don't work in rural settings in many cases.
No, totally. So I'm from Appalachian, Pennsylvania, and we still do not have broadband. And you it's an hour and a half to Philly, right? Like, so we don't have rideshare where I'm from. Like, you really have to you really have to navigate if you need some sort of care, and all this telehealth stuff. Like, I use Alaska as an example often, right? Like, sure, I guess we could get everybody Starlink, like awesome, totally cool. But how does telehealth fit into the work y'all are doing? Is it like kind of enabling this navigator to do more, or is it like a key part of the solution, or is it not anywhere close?
Yeah, so we don't really do a whole lot with telehealth at this point unless the practice is already willing to or wants to do telehealth. And then in that case, the navigator will get involved. I think more so our navigator we'll talk to them however they're willing to talk, whether it's, in person, whether it's a phone call, whether they want to text. So they kind of meet the patient where they are and try to make sure they're getting them to the things they need to do and helping them get access. Sometimes they'll say, oh, well, I'm waiting for 3 months to see my GI doctor and I'm having this problem. And well, they can call the GI doctor and say, hey, like we have this problem. Let's figure out how to get them in earlier or find someone else to see them. So there are ways around, problems that are happening. Some things are totally fine to wait 3 months for. So they, intervene and help with that kind of information as well.
Well, I'm totally into this. So as you know, I did I was on the leadership team of Collective Medical. I still do a lot of work with point click care, a lot of ADT all the time. And we had these amazing outcomes, but like what everybody needs to realize is who was actually looking at that data were the ED social workers and the social workers in the community. And like, that's what actually made the secret sauce happen, was like getting them what they needed at the point of care and doing all the work and like actually caring about the patients that they had, finding them, driving to the ED, all that stuff was what really made the magic happen. So like, I'm totally here for this 100%.
And just a shout out from the comments from Pooja from Point of Care Partners, not Point of Care Partners, it's a cute little merger of the words, Point of Care Partners. She is calling out that we need ADT feeds to go to pharmacists as well, especially in rural areas where pharmacists are often a really, really, in many places, but also in rural areas, a really critical provider, a caregiver, a scheduled, a licensed clinician who can provide tons of important care. So just a shout out there for pharmacy as well.
We also need to help rural health systems connect to ADT feeds. A lot of them aren't connected. And so that's, we encourage any other rural communities to join into the HIE or to other solutions that provide ADT feeds, because there are big gaps in those as well. And honestly, they're too complicated for your average practice to take up, we find. So, we do a lot with the ADT feeds to clean them and make them make sense. Sometimes you get a discharge before you get an admit, or you get a transfer because they got a radiology test from the ER to the inpatient to the ER. All that is a little bit confusing to take in. And so it takes a lot of work to make it simple and easy for the provider and helpful for them or for the navigator.
That's what I was going to say, is that I assume that's part of your role, or part of what you all do, is finding ways to take in the many disparate feeds of information and put it into an actionable format for someone in a rural health care setting that they can actually act on. I'm just assuming from what you're saying here.
You got it. Yes, that's a big part, is the simplicity of it, for sure. I mean, I heard on the last person he's talking about paper charts, and we still have practices that have paper charts. There's no ADT feed going into their paper chart, but we can give them a piece of paper that says, these are the people that were discharged yesterday. These are the people that were admitted yesterday. These are the people that didn't pick up their meds. Our navigator's calling these people, but letting that kind of thing. So.
I freaking love that. Yeah. And then Pooja, to keep shouting her out, I know she posted something in the past couple of days about connecting pharmacies to the broader care continuum. And there was a complex chart involved. So I didn't read it yet, but I do think, pharmacists can play a huge role. I know in West Virginia, that was one of the reasons that they had early high vaccination rates, right? It's because they have a high rate of independent pharmacists, and there was trust in the community. And it sounds like that's what you're doing with your navigators, is they're from the community, people trust them, you're getting over some of that medical mistrust to get them the care they need. And someone who's actually going to spend the time to figure it out. Like you said, the church that's going to actually drive you, or where you can get food or anything like that. So I love it. I'm totally into it. Oh my gosh. I didn't know this. I didn't know you were doing this.
I did. Where were you, Kat? Jeez.
I don't know, Lisa. I was too busy thinking about when I'm reincarnated and become a man senator. Yeah. I was really, I don't know. I was thinking about it, or I was too busy complaining on LinkedIn about interoperability. I guess I missed it. So I don't know.
Whatever. Fine.
All right, Amy, we're almost out of time. So what do you want to leave our loyal fans with? What kind of go do stuff, call to action, or not, whatever you want to say?
Yeah, I mean, as a patient and caregiver, I echo a lot of things that were said just a little while ago. It's really hard to get your data. And as a provider, there's still a lot of gaps as well. So I'm hoping TEFCA is going to bring some change, but I don't really see a whole lot there yet. So I'm still, when I started in EMRs in 1996, I'm very old. The whole mantra was, it's all going to be connected by the year 2000. And here we are still trying to get data connected. So
in a minute.
I want that dream to actually come true. And I think a lot of people are working on it. And I also would say that the government needs smart people. Please give your time and go do a tour in the government, because nobody else is going to do it. We need some smart people to sign up.
Right. That's right. I agree.
Yeah.
Thank you, Amy.
God bless America. Yeah. Thank you, Amy. You're the best. You're the best. All right, Lisa, it's just us. What are we going to do? Talk about the unions? What do you want to do?
I'm just gonna shout out friend of the show, actual friend, real friend, Emily Peters, just saying that she was appreciating the grounding perspective in the show today. Everyone's talking about AI, but so many communities still lack high-speed internet access, for sure. I mean, as you all know, where I live in Marin County, we barely have 5G. So, it's about 35 minutes from San Francisco.
It is really frustrating when Lisa sends me messages. Sometimes it spins until she gets back to Wi-Fi, because isn't that because they think they're scared of the EMF?
Yes.
In Marin County. Isn't that why? Yeah, I don't know. So there's all kinds of reasons we don't have high-speed internet, guys. It isn't always because we're living in Alaska or the Appalachians. I don't know. By the way, it's Appalachian.
Infrastructure is hard. Infrastructure is hard.
Infrastructure is hard.
And these are all
and like Shamekka was saying, right? We're talking about AI and fancy shit, and guess what? Some of us can't even get our freaking data. So let's think about let's solve the analog problem before we do hardcore stuff. I don't know. Also, I am going to go to the Vietnamese place and have a big old bowl of pho, because I'm freaking tired and don't feel good, and I was on an airplane. So
Yeah, you guys. Just it's time for the weekend, which was brought to you by unions. If you weren't sure, it is weekend
Big
time. Brought to you
labor.
by union.
Big
We used to have
labor.
to work
Vote
7
for
days a week.
Kat as a
Now
man
just
when
6
I'm
and a half.
reincarnated.
Vote for Kat when she's reincarnated as a man senator, not just a
Yep.
U.S. senator. We'll make her
Like
a U.S.
I'm definitely going to be a U.S. senator. Lisa, you
US.
can be president. I will make
Great.
it hard on you. I will block all your budget proposals.
I believe it.
It's going to be fucking
believe
crazy.
it.
All right.
I
God
believe
bless
it.
America.
Thank
Go
you.
join the
See y'all
government.
later.
Public service
Thanks,
is amazing.